Hi, good morning. I'm David Cohen from St. Luke's Mid-America Heart Institute in Kansas City, and I'm pleased to be here in Seoul, Korea with a number of colleagues and good friends who will be speaking about antithrombotic and antiplatelet therapies this morning. I'm joined by Matt Price from San Diego, Freek Verheugt from Amsterdam, and Dominick Angiolillo from Jacksonville. We really have world experts on antiplatelet and antithrombin therapy in ACS and in PCI. So I'm going to be going through a number of different issues that we're going to try to cover this morning in the next 30 minutes or so. We're going to be talking about the new P2Y12 inhibitors, a topic we discussed at some length this morning. We can get into it in a little bit more detail and a little more nitty-gritty here, talking about both prasugrel and ticagrelor and issues around their adoption and their appropriate use. We will talk about the area that we have the two of the world's experts in monitoring of antiplatelet therapy and the Gravitas and Arctic trials, and we're lucky that Matt's the PI of Gravitas trial, so he can tell us what was good and what was bad about the trial and if he would do it differently again. And then we're going to talk about the oral 10A inhibitors, and we have one of the world's leading experts on oral antithrombotic therapy, so we'll enjoy that discussion. And then we will finish up, not shown on this slide, talking about the newest antiplatelet drug, cangrelor, that Dominick at least knows very well, and try to shed some light on the Champion Phoenix trial and where that might fit into our armamentarium. So we've got a lot of stuff to cover. And let's just kind of refresh your memory. I don't think I need to refresh these guys' memories, but for the rest of the audience, the first of the new antiplatelet drugs was studied in the Triton TIMI-38 trial, randomized double-blind comparison of prasugrel versus clopidogrel in about 13,000 patients undergoing PCI in the ACS setting, with a substantial benefit, about a 19% relative risk reduction of the composite of CV death, MI, and stroke, with prasugrel driven mainly by MI, but with some excess of bleeding, including an excess of fatal bleeding, so some concerns there. The more recent study that was done with prasugrel was the Trilogy ACS trial, which was a study of patients with the intent for medical therapy, so a very different group of patients, a very sick and complex and challenging group of patients who were being randomized in that case after medical therapy was decided to either clopidogrel or prasugrel, with the option for a low dose of prasugrel in patients who were at higher risk of bleeding, such as the elderly and low body weight patients. And this study was somewhat of a disappointment, which really showed over about a 2-year follow-up period no benefit, although there was this very interesting finding that it seemed like at a year the curves started to diverge, although the overall benefit was certainly not statistically significant. The good news was there wasn't an excess of TIMI major bleeding, even though these patients were quite high risk and complex. And then the third study in this panoply is the Plato Study, which I think everyone here knows quite well, which was a broad study of patients with ACS undergoing either PCI or medical therapy or even CABG, treated upstream before diagnostic angiography with either clopidogrel or ticagrelor for a long-term period. Again, the triple composite endpoint of CV death, MI, or stroke, which was reduced by about 16% with ticagrelor. And interestingly, in the overall trial, there was no excess of bleeding, although if one looks specifically at non-CABG TIMI major bleeding, that was increased. And then very strikingly, there was about a 20% relative reduction in cardiovascular and all-cause mortality, which really is the standout finding from this particular trial. So we have 2 new agents, at least 3 trials that we can discuss, a number of different populations. And I think what we want to discuss really is how these drugs are being used and maybe how they should be used. Because as we talked about this morning, the uptake of these drugs, certainly in the United States, has been relatively disappointing. I think certainly to the companies who make them and spent all the money on the trials, that's for sure. But I think to some of us who find these drugs to be pretty useful and think that they are beneficial to a pretty broad range of patients. So let me ask, first of all, so in the U.S. we know there's been reasonable uptake of these drugs in STEMI, but in non-STEMI ACS, not that much. Freek, can you comment a little bit on what's going on in Europe? We know these drugs are recommended Class 1 in the guidelines. What are we seeing in Europe?
In Europe we see the same pattern. that it's a very slow uptake. There is a large Swedish registry until January 1st, 2013, showing that less than 20% of patients, ACS patients, do get these very effective agents. And price may be an issue, but also the bleeding, because both new drugs increase bleeding. And there's a good alternative. There's clopidogrel. It's cheap, it's effective, and we know how to handle it. So I think doctors are a little bit afraid using new drugs in the first place, but especially since we have a good alternative.
Well, so let me push back on that a little bit. Say, is clopidogrel really a good alternative?
Yes,
if we so in my view, and you please challenge me if you disagree, anybody, if I look at the data from the CURE trial, which is the trial that established clopidogrel relative to placebo at the time, and then I look at the data from Triton or from the Plato trial with prasugrel or ticagrelor, I see that the benefit of the newer agents over clopidogrel is exactly the same as the benefit of clopidogrel over placebo. And so I would say that they are not good alternatives. They are.
Doctors think differently.
Okay.
You know, the statins were taken up very rapidly because there was no alternative. Clopidogrel was taken up very quickly because there was no alternative. And the same is true with the new anticoagulants in atrial fibrillation. There is still a good alternative. So I think that is the...
So alternative means I give something.
It does something, although it's complex with regard to anticoagulation. Clopidogrel we know very well, and it is for nothing. It's
right. Well, it's cheap. It's
very cheap.
Is there a big cost difference for your patients in the Netherlands? Even with public insurance, they have to pay different out of pocket?
Because the government is also keen on money.
Savings. Okay.
Yeah,
so they have to charge them. What do you think? What are the challenges, in your own practice and in the United States?
I would say the main challenge in our practice is cost. We really try to use the new agents in all of our ACS patients that come to the cath lab. But then when it's time to discharge the patient, or maybe when we're seeing them after 1 month, we are sort of handcuffed and we need to switch to a generic clopidogrel. So I say cost is the definitive driver. At our center, I would say that experience perhaps is not the main problem because we've been main drivers in the clinical trials and we do have a lot of experience with handling, but I can understand many of the interventional cardiologists out there. They feel very comfortable with clopidogrel and they are very concerned with some of the bleeding hazards. So I think this is one of the two main reasons why the uptake has been quite slow.
Matt, you look like you're itching to say something.
Yeah, because it's interesting in that cost is clearly a problem. But if doctors and patients believed it was worth the cost, it wouldn't be a problem. I think and I'll steal something from you, Dave, is that I think there's a lack of a tactile feel for the events that occur, the ischemic events that occur, as opposed to the bleeding events.
Because they're delayed, because they're non-STEMIs, or they happen months later, or
right. Well, and also you're preventing ischemic events and causing bleeding events,
so it's
and also the overall horrific events like stent thrombosis and cardiovascular death or all-cause mortality. The rates are fairly low, so that if you saw your patients dropping dead or having stent thrombosis at a large number on clopidogrel, you wouldn't care what the cost was nearly as much. So now it's become an abstract goal. And it's hard to balance an abstract goal with the patient saying this is costing me $45 a month.
Right. No, I that's what I said, and so and I believe it. The difference between these errors of commission, errors of omission, that if somebody bleeds late after, when they're on a more potent agent, they come back to your hospital, you feel, as the cardiologist who put them on the more potent agent, you feel responsible. If they happen to die suddenly 9 months later, maybe you don't hear about it. Or if they do, you think, well, they had coronary disease. It was,
act of God.
Right, yeah, exactly.
And bleeding is on us.
Yeah, so but it's not right. I mean, we should not act that way. That's not rational. It's not
how it works.
Right. And even if you take bleeding out of the equation, the events on clopidogrel therapy are fairly low enough that the doctor, I don't think physicians really see the rationale for having to push something that costs more money.
So the question really, I think, to me, comes down to whether you believe the mortality benefit, especially with ticagrelor, because again, it seems to me that if we really had conviction about that mortality benefit, we would push these drugs more. We would really say to our patients, this is life-saving therapy for you. We don't hesitate to put in defibrillators. We don't hesitate to give to push beta blockers in patients with heart failure or any of those kind of things. Do we not believe that there's a mortality reduction?
I think the mortality benefit in the trial is real. It's been consistently shown in the various subgroups. We can't fully explain it. I do not interpret this as part of the bleeding concept within the trial. I think there's something additional related to this new class of agent, and. But it's interesting, what's the value of an individual's life?
Right.
And mortality benefit trumps all.
One would think.
That's something I discuss with my fellows all the time when we're prescribing these newer drugs. Say ticagrelor, and they'll say, well, I had a patient with dyspnea. Do you really want to prescribe it? And I say, well, what's a life worth to you? I mean, so the patient has dyspnea, maybe we'll have to switch the drug, but you may be saving a life. So there's, I think, a valuable trade-off there.
I think it definitely is interesting. To me, it does put a big challenge on the interventional cardiologist to talk to the patient in ways that we perhaps have not had to do. We said, okay, clopidogrel, you have to take your clopidogrel. You can't stop that because you'll have stent thrombosis, or something horrible. Although, again, the reduction in stent thrombosis is if you really go back to the original, STARS trial, it was a 2%, 2.5% absolute reduction in stent thrombosis. There wasn't a mortality reduction in that study. So it's, I think we have to believe the data, and part of it is maybe we don't understand the data.
The other issue which falls part of this conversation in some of the limitations in uptake is concerns about switching. And again, interventional cardiologists sometimes say, well, patient is doing okay on clopidogrel, why should I consider one of the new agents? And there's been a lot of concerns about overdosing, interactions, and whatnot. My opinion, I think the switching concept is very, very simple. Because there aren't any drug interactions, with exceptions of cangrelor, but that's a different story. And so in my practice, if I have a patient who's on clopidogrel, even if the patient was loaded just an hour before, and I believe that patient could benefit of a newer agent, I just switch to the newer agent, starting off with a loading dose.
So either one?
Either one.
Okay.
And we have data from
the same?
Yeah, the Plato trial switched patients
with ticagrelor.
With ticagrelor. So unlike the Synergy study, for example, where there is this nefarious concept of switching, maybe troublesome. In fact, it was built into the trial. About, I think, 40% of the patients or so were on clopidogrel prior, and there was still a benefit. So here we have randomized clinical trial data to support switching from clopidogrel to ticagrelor, and that's.
But I think the bleeding is the biggest hurdle, because when there's a new drug, you get bleeding. The bleeding is on us.
Right.
Yeah.
We forget that clopidogrel also increases bleeding at least the same extent versus placebo as ticagrelor does against clopidogrel, as prasugrel does against clopidogrel. It's just the time. Time is our best friend, I think.
Time experience with the drug.
Time experience, and of course the cost issue is also there, but the bleeding issue is the major point. If a patient gets a bleed on warfarin in atrial fibrillation, they say, it's act of God, because this is, you need to give warfarin. Yeah, and we know, it happens.
Yeah.
Shit happens,
right, exactly.
And if a patient gets bleeding on prasugrel or ticagrelor, it's your problem.
Yeah.
You switch this new agent where we know that this increases bleeding, and
or as
here we are. You see.
Yeah, as Matt points out, time experience, comfort. For sure, all of those things, and then the cost will come down at some point when it becomes generic.
Clopidogrel had the fortune that we got the stents. Clopidogrel was given in non-stented patients in cure. It had a benefit, but then the whole issue came of stent thrombosis, and then that's why clopidogrel was taken up so quickly. since we now have better stents and better interventionalists, why do we need new antiplatelet drugs? Torpedo does the trick.
I think. Well, it's. I think we. What you're testifying there to is the ability of our minds to play tricks on us, because again, it makes us. We make a lot of decisions that if you stand back and you look at it, very objectively with the clinical trial data in hand, it doesn't make sense. It's not what we should do. But we have a lot of biases. We're human beings after all, and we don't act rationally. Human beings are far from rational decision makers in most things. So I think that's kind of what we're emphasizing. Well, let's move on, just because we could probably talk about this for the rest of the half hour, but we wouldn't have any time. So now let's talk about your favorite topics: platelet testing, platelet function testing, and therapy adjustment. Matt, you know this trial well, the Gravitas trial that you designed, and many of us were a part of, where patients undergoing elective or urgent PCI with drug-eluting stents were tested with the Verify Now assay, and at a threshold of 230, they were then classified as being poor responders and entered into the trial, where the randomization then was between a higher dose clopidogrel versus standard dose clopidogrel. And as you showed this morning, there was no benefit. It's hard to make the curves any tighter than this. You might have, you'd have to fake it to make them any closer than this. There was really absolutely no benefit on the primary endpoint. No subgroups, no nothing. And then we had the Arctic trial, which is a very confusing trial, I must admit, that you presented this morning, where patients were tested actually before they underwent the PCI procedure with the same assay, the Verify Now bedside antiplatelet assay. And then there was dose adjustment, which was, as you again alluded to, really there were recommendations for different things one could do. Could give a GP2B3 inhibitor, one could increase the dose of clopidogrel, one could switch to a novel agent, in this case prasugrel. And again, it was retested and readjustment was allowed. And once again, there was absolutely no benefit whatsoever, although the endpoint was driven almost entirely by periprocedural MIs defined by a troponin elevation, which maybe is not the most important endpoint for this type of a study. And in fact, if anything, the monitoring group and the adjustment group did a little bit worse. And then we have the observational data, which, again, both you and Dominick have contributed more than most to. This is a platelet function sub-study that Paul Goebel did in conjunction with the Trilogy trial, where a very large number of medically managed ACS patients were randomized to prasugrel or clopidogrel. Platelet function testing was performed multiple times during the study, confirming that prasugrel led to a much greater response and a much lower percentage with high on-treatment platelet reactivity, and yet there was no clinical benefit overall in the trial. And then there was this very interesting, fairly complicated analysis that Paul presented, and that maybe you guys can comment on a little bit, where there was clearly an association between the PRU level and cardiovascular events in unadjusted analyses, but when they adjusted for other factors, other baseline differences, it actually went away, at least suggesting that perhaps the PRU is more of a marker of other conditions than actually measuring what we think it is, which to me is a little bit counterintuitive. And so let's come back to the question that you guys just debated very eloquently this morning about the role of platelet function testing these days in our practice, and what can we do going forward. Again, it makes good sense. Matt, you've emphasized. I mean, the platelet is what we're inhibiting with these drugs. If we measure the platelet inhibition and it's not affected, you haven't given the drug. So it makes good sense to do it. So why? Let's talk first of all about why the results have been disappointing. Why have the trials failed to date? And let me ask, or I guess failed. That's not a nice thing to say. But why have the right? Why exactly? Dominick said it right this morning. The trial was neutral. So why have the results been neutral? And has that dissuaded you from your interest in this field and in these types of tests?
Well, I think we need to step back, take one step back, and think about how we apply the results of randomized clinical trials to our patients. Is we look at the population that was represented in that trial and then can extrapolate to the patient in front of us. And those studies that you have mentioned, the populations that were studied in Gravitas and Arctic were predominantly elective PCI, stable CAD. ACS patients were not addressed. And then in the Trilogy trial is really patients that were recovering from ACS that were treated medically. This is not a PCI population. And so, and we can talk about the adjustment. There's been some criticism that they basically adjusted for everything, including the kitchen sink. And at a certain point, if you adjust for everything, nothing will fall out. That being said, we saw in the overall trial that more intensive antiplatelet therapy did not improve outcomes. So I think it's actually a mechanistic explanation of the overall trial that in the population that was selected for in Trilogy, basically patients on average 4.5 days after presentation with ACS who did not get a stent, in that group of patients, intensified antiplatelet therapy is not helpful. And the platelet function substudy supports mechanistically that hypothesis. But again, stepping back, we see from these studies and we see from our experience in drug-eluting stent studies with new generation stents that the absolute event rates in elective PCI are low. You know, and in fact, patients can be non-compliant with these new stents, and they don't all have stent thromboses.
Right.
A very small number have stent thromboses. So perhaps platelet function is prognostic in those patients, but the absolute risk reduction one can achieve is so small that no matter how many patients we look at, we won't see
with elective PCI. So so do we need just to do an ACS trial? Do we need to redo with the Triton trial with testing in ACS?
I think that if we are going to move forward in the field, we need to look at the evidence and the data that we have so far based on Gravitas, Arctic, and Trigger PCI, and definitely patient selection is key. As Matthew highlighted, we need to have a population which is enriched with clinical events. And I can say that out of all of this, for example, even out of Gravitas, a good news is that we're doing a pretty good job in the cath lab in keeping event rates low. Gravitas, in the setting of a high-risk patient population, high biological risk, and also high interventional risk, although it was not an ACS population, event rates were 2.3%. And so moving forward, we really need to think about how we can find an enriched population. And I wanted to make a comment regarding the Trilogy platelet function sub-study, and just to add upon what Matthew was saying, let's not forget we're looking at a sub-study in the setting of a trial that did not meet the primary endpoint. So always important when we look at this, and because one can say, well, what if the sub-study would have shown positive results, then we would have been torn with, well, what does this mean?
Even a worse problem? Okay, we have because we still have a trial that did not.
Exactly. And then we have getting finalizing, and we have Arctic. But what happened with Arctic, I like a lot the concept of the trial, but the trial was not executed to the extent that one would have expected, because in the monitoring arm, we had a large number of patients who really did not reach the predefined thresholds of optimal antiplatelet therapy. So again, a lot of limitations to the trial. I think we need to learn from these and try to do something for the future, because as Matthew eloquently highlighted this morning, we can't use the new agents for everybody. It's going to be too expensive. We're going to be exposing a considerable number of patients to higher risk of bleeding, and we need to select those patients where I love that slide. The number needed to treat is reasonable to justify the use of these newer agents.
So, Freek, let me ask you. You're a clinical trialist. Do we need clinical trials to test platelet function testing? Because I mean, one of the things that I'm always struck by is we have many diagnostic tools in our armamentarium. Almost none of them have been subject to a rigorous study to improve outcomes. Yet we do them all the time. We do. We check people's cholesterols and CRPs and many of these different, different sorts of things, and we order, echocardiograms. I don't know. I'm not aware of any randomized clinical trial that shows that stress testing leads to improved outcomes. I'm not aware of any randomized clinical trial that shows that echocardiography in heart failure leads to improved outcomes. Are we holding platelet function testing to too strong of a standard?
I still think, and I said it already this morning, I think the hypothesis is very clear. If you have very reactive platelets, you will end up in more trouble. I think that's correct. Stronger drugs improve outcome, correct. But the test maybe is the wrong test, or we do not know the right test. But for instance, I disagree with you. With the INR, for instance, we know that it is a good measurement for a proper treatment. There has been studies of fixed dose warfarin versus adjusted INR adjusted dose, and those trials.
So that's one where we have the data.
SPAF3, for instance, there we have data that proper testing gives better outcome, so I think you need better tests, better platelet function tests than we currently have. That's my personal view.
Do you agree, Matt? Or
Although we have two experts here.
Yeah. So because let's say earlier you said that clopidogrel is a great drug.
Yes.
Let's say the first clinical trial of clopidogrel was Charisma. That was the first trial we did.
Let's say it was
Negative
a positive
trial. No, let's just turn back the clock.
Okay.
And BMS Sanofi decided, we think this is a great drug for primary and secondary prevention.
Yes.
Let's do the Charisma trial. And it was negative. Would we say that we shouldn't use clopidogrel anymore? It's a loser. Or do you decide, did you look for a population where there will be benefit? And so that's why I think it's pretty clear that the platelet function test that was used in Gravitas and in Arctic is prognostic for events. I mean, there are other tests available in Europe that also have shown prognostic tests.
Okay, but
So I think that we need to target a population where there'll be maximal benefit for our intervention.
Well, certainly that would improve the risk-benefit trade-offs and other sorts of factors. Let me move on because we're running low on time, and I want to make sure we take advantage of Freek being here to talk about antithrombins. And you gave a very nice talk this morning about residual risk in these patients, and we have a number of new antithrombotic agents which are easier to work with than good old warfarin in some ways. And so there have been several important studies, the APPRAISE-2 being one of them, where patients with a recent ACS and additional factors were randomized to apixaban versus placebo, and very large scale study which was stopped early by the DSMB. Because there was no evidence whatsoever of a clinical benefit on CV death, MI, or stroke, and there was a clear harm with a very substantial increase, about a 2.5-fold increase in TIMI major bleeding, including intracranial bleeds, all the bad kind of bleeds that we most despise. And then this is in contrast to the more recent study, the Atlas ACS 2 trial that Mike Gibson ran, where again a similar population, although patients with prior stroke, as you pointed out, were excluded from this population, but patients with recent ACS who had been stabilized, they had had their PCI if they were going to have it. They were basically patients who were on the launching pad to discharge, I think, were then randomized. They all received aspirin. Many of them received double antiplatelet therapy with clopidogrel, and then were randomized to a placebo or two different low doses of rivaroxaban. Again, as Mike Gibson likes to say, it was like licking the pill, right? It was a very small dose, especially the 2.5 milligram dose. And here there was a benefit in the overall trial when the rivaroxaban doses were combined, when each of the rivaroxaban doses were looked at independently, about a 16% relative risk reduction, really the exact same relative risk reduction that was in the Plato trial, the exact same relative risk reduction that was in the Triton trial. But the striking thing in this study was a reduction in mortality once again, both cardiovascular death and all-cause mortality when looking specifically at the low-dose group. And this occurred despite the fact that there was increased bleeding and increased intracranial hemorrhage. And so, this really opens up a whole new area of therapies. And so I'd like for you to comment just a little bit on why you think the results are different between APPRAISE-2 and the Atlas 2 trial. Is it the drug? Is it the dose? Is it the population? Is it some balance of the different ones? And then maybe some thoughts about how this is going to fit into our armamentarium when we're already not using the other new agents. So go at it. Yes, please.
The first point, the dose is very important. Because in APPRAISE-2 we used the full dose, which we also used in the Aristotle trial in stroke prevention, where it was very effective against warfarin, even reduction mortality, reduction in bleeding. And so we learned a lot from the APPRAISE-2 trial that we should use a lower dose. And that's what we did in Atlas, a much lower dose. And the second thing, we used low-dose aspirin for all patients. We excluded, like you said, patients with a previous stroke, not only previous ICH, but previous stroke, because previous ischemic stroke is also a risk factor for cerebral hemorrhage. We know that already from the thrombolytic trials. So we did, I think in the second study, we did a better study. And we had a different DSMB, because if you look at the bleeding, the bleeding risk in APPRAISE-2 and Atlas-2 was very similar. The increase 2.5 times higher bleeding, major bleeding, intracranial bleeding, but the different DSMB. And we knew, at least we knew from our old warfarin studies following AMI, that the bleeding comes first and then the benefit. So the timing of the risk and the benefit is very different. Whereas with antiplatelet drugs, it's the other way around. The benefit comes early, and the risk comes
longer,
later on. So if APPRAISE-2 would have been ended, we would have seen the benefit, I think. But I think the dose was too high. And the other point, of course, is how come that a lower dose seems, in Atlas, seems better than a higher dose? We have seen that also with fondaparinux. Maybe you remember fondaparinux when it was in the phase 2. We tested 4 doses, 2.5 milligrams once daily, 5, 10, and 12. And the lowest event, the best benefit was with the lowest dose of fondaparinux. And that went forward to OASIS 5 and 6, where OASIS 5 and 6 had a strong mortality benefit. So the dosing with anticoagulant is crucial, like we know from warfarin, INR, where the dosing for antiplatelet drugs is, I think, very unimportant. We did a 26,000 patient study called Current OASIS 7 to show that there was no difference in aspirin nor with clopidogrel. So oral anticoagulation, also with the newer agents, the dosing is very important.
So do you think, I mean, so we already said the doctors, around the world are scared to use the new antiplatelet drugs because they're costly and they cause people to bleed.
Yeah.
Are people going to be scared to use?
Absolutely. It will be the same story like we have with atrial fibrillation. The uptake of the bigatran is still rather low in Europe, and I think also in the US, where everybody loves to hate warfarin. And still, because of the issue of the bleeding is on us when we use a new drug. The bleeding is on God if it is on warfarin or clopidogrel, because we know these drugs for many years.
So let me finish one more question, then we'll finish up with talking about the Champion study. So if we have two drugs now in ACS populations, different timing, things like that have been shown to lower mortality. We have ticagrelor, we have low-dose rivaroxaban. If you have a patient who's low dose for low risk for bleeding, a patient with a STEMI, perhaps, and you need to think about pathways. How are we going to manage these patients? Is there any rationale on which to base a choice between those two choices? Because I think right now we're not going to give both. I think we would be worried still about excessive risk of bleeding with too potent agents.
There's a big difference between, for instance, the Plato and Triton study. These were acute studies, where APPRAISE and Atlas were typical secondary prevention studies, like Trilogy. Trilogy, it took 4 days to get them on the stronger antiplatelet drug. No benefit. In my view, strong antiplatelet drugs are very good in the early days of ACS, whether it's STEMI, non-STEMI, where anticoagulants, maybe you need to stabilize the patient first, put a stent in, do a good revasc, and then protect them for the long term.
So you, I think indirectly are arguing for a strategy completely untested of giving a very potent second-generation antiplatelet drug like ticagrelor or prasugrel for a week. But for a week, and then then go back to clopidogrel and switching on to rivaroxaban, something outside of the bounds of anything that's been tested so far.
With or without aspirin, because that's another discussion. Okay. Should we continue giving aspirin to all?
Right now we have to, because even the studies have done it with aspirin, but maybe there will be more studies without. Did you want to make a quick comment?
I think that Freek really highlighted something that's going to be very critical as we move forward with clinical trial development with the antithrombotics in general, which is doing solid phase 2 studies, good dose-finding studies. We spoke about the PRAISE experience, we spoke about the ATLAS experience, we spoke about the funded Paradox experience. And what the trials have shown, particularly with the anti-10, you clearly see this direct dose relationship on bleeding and an indirect effect on ischemic events. And with the lower doses, really finding that sweet spot. And that's where I strongly believe, in addition to patient selection, why ATLAS really succeeded, because they took the data from their very well done phase 2, very well done, and came up with a dose.
Well, maybe it does argue a little bit more for, these multi-arm, phase 3 trials, because again, the ATLAS trial did have 2 arms. We know the Pegasus trial is now being run with two active arms, that you can, you can hedge your bet. Maybe you find the right one. Finish up talking about the Champion Phoenix study. I think, Dominick, you were involved in the study, I think. Were you involved as well, Matt? Or? So you guys are all involved. All right. So
I was DSMB of this.
You were the DSMB. Okay. All right. So we got everybody.
And the 2 previous ones as well.
Okay. Well, I was uninvolved in the study, but this is it's called Phoenix, right? Because it was trying to resurrect the drug from the dead. Cangrelor. So it was a study, cath lab based a study where patients were, some with ACS, some with stable coronary disease, were randomized in the cath lab to get a Cangrelor bolus or to get placebo. And then they were given a clopidogrel in the cath lab. So it was, and some people have said this is a study of Cangrelor versus placebo, essentially, because we know the timing when clopidogrel was given, it was not active during the cath lab. And there was benefit on the primary endpoint of death, MI, stent thrombosis, and these sort of intraprocedural thrombotic events, ischemia-driven revascularization. And looking at the different endpoints, one of the things that was reduced was stent thrombosis, although a non-trivial number of these stent thromboses were intraprocedural thrombus, hazy vessel, slow flow, things like that were observed in this trial. There was a clear reduction in MI, no reduction in death, although again this is a 48-hour trial. It would be illogical to think there would be a reduction in mortality. Here's the curves, again, a very early benefit reflecting that most of it was intraprocedural events that were being prevented. And here's the stent thrombosis data. And so my question, and these are my own questions, are these clinical results compelling? And in particular, what is it? I mean, how are we going to use this drug when our guidelines say we need to give upstream therapy, and that was not compared? And then our guidelines say we should be using more potent antiplatelet agents, and those weren't compared. So is this just another option? Where's it going to fit? Dominick?
Yeah, that's a very good point. Obviously, there are critiques to the trial based on some of the aspects of trial design, which may not fit with everyone's practice. But the trial does fit a lot with many practices, particularly in the United States, where patients are not necessarily being pre-treated with clopidogrel. And in a direct way of highlighting this, the trial enrolled really quickly. So centers did have these patients.
Oh, and lots of people are treated this way. So I think that's
exactly
fair. Yeah,
so it is a new treatment. It is a new treatment option. I think the data are compelling. One can raise the argument, was it fair play? Well, again, the trial was conducted in that specific setting. I do see a lot of value for the drug in certain settings, such as STEMI, where we know even the new agents takes several hours to kick in. There are 2 reports now. But let's also not forget about patients who cannot take the drugs orally, patients in shock, in addition to your procedure, even your stable patient, where you may have a long procedure. And how many of us do these procedures just give heparin, the patient's on aspirin, and does not give clopidogrel until the end of the procedure? And so again, we have a new drug, which was tested in a trial based on errors learned from 2 previous trials. If you think about it, I'm not aware of other phase 3 clinical trials which were developed based on 2
other failed studies.
Phase 3
the 3 strikes and you're out principle, is that?
Sure, for Freek, you're on the DSMB. This is clearly a safe drug. With 30,000 patients now have been studied with this drug in phase 3 trials.
They're very short.
Yeah.
No, I think it's. But I mean, so is your practice in? So let's think about ACS patients, because again, I think personally doubt that it has a hell of a lot of benefit in the elective patients. I mean, again, just hard to show any benefit of anything in elective patients.
Well,
but in the ACS patients, are you preloading your patients, these days? Or are you not preloading?
I try really hard to pre-treat.
Okay.
I tell my team to pre-treat, but
they still don't.
They still don't. And I would say about 50% of the time they manage to
Okay.
get pre-treated. And also the time to the cath labs now is very short, even in non-STEMI during the daylight hours.
Sure.
So that even if you were to give 600 of clopidogrel, it wouldn't kick in until you're after.
But shouldn't we be giving 180 of ticagrelor and it's already kicked in by by the time they get to you?
I think we should be, but the fact is that we're not.
Yeah. Well,
we're not even giving it after the procedure. So I do think that this is a tool that will be very comfortable for interventional cardiologists to use.
Sure. Because it'll be the time frame when you're using it. I think to me it's a very interesting study because I think it's a study that can get the drug approved, but I think it's going to be used very differently, and so that's strange. What do you think is going to be the uptake of this drug in Europe?
I think it will be very low because many patients in Europe are already pre-treated with clopidogrel.
Right.
Because our surgeons are not so afraid as yours in operating on patients on clopidogrel. And my old professor of surgery always said a good surgeon is a dry surgeon.
Regardless.
So if the patient is on clopidogrel, you need some more time to really make the patient dry.
Right. So people will be skeptical as to whether there's a benefit compared against.
No, there is a benefit. It's a very good trial.
But against placebo, essentially, there was a benefit, which is what was given.
But most patients, at least in my country and many other European countries, are already preloaded.
So it doesn't apply so well to your
Yet, if you look at the ACOS data, which we hope to present in the summer in Amsterdam at the ESC, or Dr. Montelesco will hopefully present it, there you see if you give prasugrel too early, then you may end up with bleeding. So the preloading with the new drugs, even clopidogrel, has not been really proven, and at least in ACS patients, whether this is really helpful.
Right. Well, I think that's
so, that may be an interesting alternative.
Right. I think that's going to be the interesting point is whether we will no longer pre-treat. I think. Dominick, do you have any final words on the study? It's a very important study, and it's going to have a big influence.
The last thing I wanted to add is that as you know, the concept of pre-treatment has been highly debated whether or not beneficial or not. I know the guidelines do say to do it. There's been a recent meta-analysis from Joe Montelesco, which has strongly debated the value of pre-treatment, with the exception of STEMI. Again, a lot depends on what your practice pattern is. As Matthew alluded to, time to the cath lab is really quick. So in my place, we don't pre-treat because patients are coming to the cath lab pretty soon. Our surgeons don't want to operate on clopidogrel, and they don't want to wait either. And so I think this is a drug that comes in pretty handy. And I'm sure we're going to be using the drug in different ways, which outside the way it was used in the trial. So time will tell.
Yeah, no, I think it's very interesting. Well, let me thank all of you for a really great discussion. I learned from it. Hopefully, you learned from each other, and we'll look forward to seeing all the products of all these great thoughts over the coming years. Thanks again for your
Thank you.
Thank you.